Hello, this is David Harrington, President of Center for Neuro Skills.
And this is Chris Persel. I'm the Regional Director of Clinical Services and the Director of Behavior Programming at the Center for Neuro Skills. Just like getting that medical attention when you have the stroke as quickly as possible, well, rehab, it's the same story, right? The sooner an individual can start that process, and you're thinking, well, wow, they just suffered a very catastrophic injury of some sort, but really getting them up and moving and engaged is really important, and giving them the time, because stroke recovery, some people it may be, weeks, months. It could also be years. I think of the recovery process once something like this has occurred as kind of a lifelong issue, even though you can receive a lot of that care early on and you can get that intensity and that density of treatment early on. You're going to, I feel like I learn every single day. So there's no reason that folks suffering from brain injury and stroke aren't going to be the same. But not every physician even understands that, right? These emergency room physicians, the ICU, the hospital physicians, they're into life-saving, they're into helping you. And, we certainly appreciate all of that focus that they have, but sometimes they're not aware of the struggle that's going to occur in our world, in this rehabilitation world that is weeks and months down the road for this individual. And, folks that are older, they're going to possibly have mobility problems, and that takes a while to sort of rebuild those skills. And, maybe it's vision. And I know you've done a lot of work in and speaking about visual issues, and we know how much that impacts the world that we're trying to live in. And you have to be able to see and do what it is you have in front of you. And if you're not able to see it properly, then that can really be an issue. And one thing that I think is really important in jumping in here is that once these folks can get engaged again in valued activities and activities that help them see, like the artist I spoke about, and, or the carpenter that we've seen here before that's now able to build a birdhouse or a bench for his house, and the painter who now has something displayed in our lobby. I think once they're able to see that being engaged again, it fulfills their life, their quality of life, their ability to feel like they're contributing again is so important to these folks.
Yeah, Chris, for a long time, people, the conventional wisdom, I touched upon it earlier, but it's important to kind of circle back to. The conventional wisdom is that when you had some type of stroke and you had damage to the brain, that was lifelong damage. That's the best you're going to get. And in fact, that's where CNS was born. Our founder, Dr. Mark Ashley, and his brother Steve, and your employee number 2, you've been around, you worked with Steve, and so you were one of the frontiersmen, going out and really experimenting and seeing what we can do for people who have these problems. And what you all did in the early days of CNS is really to prove that you don't have to live lifelong with damage. Now, of course, there's certain degrees of recovery, and it depends on that heterogeneity. It depends on the density of treatment. It depends on the duration of treatment and how specialized the people are who are treating you. All that really does matter. And there are a lot of times where people give up. There's times where we will get clinicians coming from the acute rehab or perhaps even inpatient rehab where they see a patient for 2 weeks or maybe even 3 days. And you touched upon it a little bit, Chris, in terms of the perspective. Well, I got to get them out in 11 days. So they're going to the next setting. They'll be fine, but they don't see what happens after that. And sometimes after these injuries, there is a spontaneous or a rapid recovery in certain areas as inflammation goes down, that ecosystem's trying to find its homeostasis. But after a while, you realize that there's true disconnection. And I think that's where we come in, because we are like the carpenters and architects of the brain. We literally get the wires to respond and to connect again, absent of some of that spontaneous recovery. As small as it might be, it's still there. And so we're all about hope. We're all about achieving the goals that the patients have. We know that the neuroscience is behind us, and we continue to work hard on our patients to kind of overcome the effects of stroke. Sometimes it's us making sure that we're providing them the hope, but it's the grind for them every single day. And so while we have to have the hope, that hope has to be also translated to the people we treat.
And yeah, bringing up hope, I'll have to give you my quote. I always say we are the first, last, and only hope. And it's different for each patient because, again, they are all different. Sometimes we're the first folks that have come along after that hospital setting that says, you know what? We think you can get up and walk. We do think you're going to be able to do this. And sometimes we're their last hope because they've maybe tried some other things. It hasn't worked. They're frustrated. They're not making the recovery. And we have the opportunity to say, you know what? We're not going to give up. We're persistent. We're going to stick with this, and we're going to see you through this process. And sometimes we're the only hope in the sense, and I think in particularly on the behavioral side of things, sometimes other folks in healthcare don't know what to do with folks that might struggle with anger and frustration and non-participation. They don't know what to do, so they just kind of shut down. We know what to do in those situations. So sometimes we're the folks that can get them started. And that patience, it helps us develop these individualized, tailored, and specific programs that allow us to really focus in on what may make the significant changes. And I just saw this reframing on the post-acute value proposition. I thought it was a great quote, so I want to read it here. It says, humans are intended to be upright, weight-bearing, in motion, so that the sooner a patient is mobilized, the better the outcomes, fewer complications, less rehospitalization, and the likelihood that that individual will live independently, and actively. That is what we do. It's not giving up. It's being very specific about what it is our patients want and need. For example, we had a Hollywood actor, Tim Amundsen, and you might know him from Psych. He's been in a number of shows. Great guy. He was in our program, and he had a significant stroke, right? And he had trouble focusing. He had trouble ambulating, using his upper extremity on the left side. So, our goal was to partner with him and say, where do you want to go? What specifically do we need to work on? Well, what do you think? He wanted to be able to get back to his passion, which was doing acting. And so his cognitive therapist would talk about scripts with him, and they would run through scripts. I saw him many times in the hallway work. I mean, that guy was working so hard on being able to ambulate and move in a smooth way because that was going to be important for him in what he's doing. And he's able to get back. He's been, I've seen him on news programs. I've seen him in his show again. And, I think the Hollywood system embraced him, which was awesome because sometimes there's a stigma there, but they were able to see what he was capable of doing and see that he had made that kind of a recovery. And it's really was just an incredible story. And I think just shows you that we will, if it's that carpenter I spoke about, how is he going to be able to hammer a nail? Can he use both hands again to be able to do that? If it's the artist, how can she mix her paints and, manage that canvas again? So, it really is taking the whole person, but really specifically tailoring and sticking to it, stick-to-itiveness, hanging in there and through the difficult times and helping them see that pathway to recovery.
Yeah, and Tim's such a great advocate, and I appreciate what he's been able to do, and not only for CNS, but really as an advocate for people who've had strokes and the recovery and what's required of that. So he's a great example. And as you said, not everyone's a movie star. There are many times where we're treating a lawyer, and we've had one where they had a brain tumor and a stroke. The case manager really helped to set up a presentation. He really presented in front of other patients. We actually had our general counsel work with the patient on law stuff. How do you manage a courtroom? How do you manage a subpoena? How do you manage all these logistics, things that perhaps you and I may not know about, but we know people who know this stuff. There were times where we had a young woman, she was in her 20s, she was a busy accountant. And so dealing with the strokes, the numbers, the visual issues, keeping up, processing information, and really focused her treatment on the numbers and the math and retaining that part of her brain. There's a gentleman that he was retired, but he was a woodworker, and that's what gave him value. And he was a little discouraged during his treatment. And I said, well, what's important to you? He said, my grandson is. Well, let's talk about your grandson a little bit. And through that conversation, I learned that his grandson bought an iguana, and he thought that it would be cool to kind of help his grandson out with this iguana. So, we got to the point where we applied all the physical, cognitive, planning, visual, and we did a power tool assessment, make sure he was safe, and we had him design an iguana cage. And he built an iguana cage for his grandson. You talk about roles, you talk about meaningful activity, and it's really taken all those performance components that we deal with, like the fine motor coordination, the vision, cognition, and frustration tolerance, and to be able to apply it to real life that's specific to that person, that's meaningful to that person, and we return people to work. And so that's where that environmental validity, one of our values, is important. I've worked in a hospital where, in order to cook something, we would wheel the patient down to a makeshift kitchen. We would have a box of brownies with a couple of ingredients. We would stir it, and then I would at that time consider that a cooking assessment. That's not a cooking assessment. A cooking assessment is trying to find all the pots and pans, to lean over, to grab things, to be able to differentiate the different knobs and to set it correctly, to be able to sequence things in the right order so that you're turning on the oven or you're putting on the pan on the stovetop before you light it, and cracking an egg. And then how do you translocate this stuff from the refrigerator and turn around and pivot without losing your balance? There's so many challenges in just an activity that's so important, and putting people in those real life environments is environmental validity. It's not what I did in other settings. It's good for that setting, for that moment, but in post-acute, we really have to take it up a notch or 2 or 10 to make sure that people are truly engaging in a real life environment to see if they're successful. I have one other example, and I'll take a breath in and let you go, Chris, with how you want to respond. There was a time where here at CNS, we do ladder evaluations. We know that people are going to go back to work as carpenters or as firemen. In this one particular case, he was a fireman, and he had to ascend and descend the ladder. Well, he was able to do that from a physical perspective, but there's some emotional perspectives that made it much more challenging. And even when he was able to do it, well, we said, well, this is easy if you're in jogging shorts and your tennis shoes and a t-shirt. Let's throw a 20-pound pack on you. Let's get your fireman's jacket. You have your helium or your oxygen tank behind you. And we had to put a big axe on his side because that's what they carry. And when he was trying to ascend the ladder and get over the edge of the ladder, that darn axe kept getting hung up. That's environmental validity. And if we had not put him in that environment with the right gear, we would not have known what to work on with him. And when we sent him back to work, we sent him back with a lot of confidence. More importantly, he went back with a lot of confidence.
Yeah, no, that's awesome. And that's, as you mentioned early on, the brain responds to those kinds of demands. And if you don't put those demands on a person, you'll never know if the brain is going to respond and if they're going to relearn and remap out those pathways. And so, I think this enriched environment, this environmental demand that is able to be accomplished in our type of a setting is so important. It is like a giant puzzle. So, you've got your physical therapy, your occupational therapy, your speech therapy, your education, your complementary integrative therapy, which is kind of combining many things together. And counseling is such a strong component. You put all those together and we find out, everybody, while they're doing their part, there may be a piece missing. And what can we do to fill that in? Let's get some fire equipment and make this happen out there. And we're able to do that. And I think, we have these inpatient programs, which give us a 24-hour environment to work with, because it's not just what occurs, for your 8 hours a day or whatever it might be during your work day or your therapy day. It's what you do when you go home at night. It's what you do in preparation for sleeping. It's what you do when you do sleep. We can also do day treatment programs because many folks maybe doing okay with some of those other things, but that intensity of treatment is really important, up to 6 hours of treatment a day. That people finish their day here and they're worn out, and that's a good thing. We've also been able to, not only through the pandemic, even before that, we were beginning to explore this option of telehealth, right? So for individuals that are safe and that are capable of being there, and there may be some people who, live in a more rural area, so getting into a rehab program may be a real challenge for them, but we found such creative ways. I was so impressed with our staff and their creativity and being able to apply it over a telehealth platform, really challenging folks. I mean, they'll have them, take their laptop into the kitchen and, like you said, in a real world, show me how you do this, or let's get some milk bottles and do some strengthening activities, whatever it might be. So it's been really important. And then, even within the therapy itself, it can be so specialized, and we make an effort to really try and stay ahead of that curve and state of the art, really important pieces of equipment that can augment what our therapists and their passion does. And that's everything from the 0G, which is a body weight supported system, so that individuals can build their confidence in ambulation without fear of falling, and they can really get those patterns of walking and mobility under control again. We get folks in a swimming pool because that buoyancy that the water provides really helps them with feeling as though they're moving in a way that's more normal and natural while being suspended by the water itself. We have, there's traditional things like therapy balls and stairs and, treadmills and all of those contribute as well. We have a health fitness program that really is focusing in on building up cardiorespiratory endurance, as well as strengthening the muscles in the core. So, it's all of these things that contribute. And let me just take a minute here to give you a case study that I found that recently an individual that was kind of in his mid-50s, so had this stroke, was able to come into our inpatient program, and he had all kinds of comorbidities. He had a right-sided infarct, and he had, visual field cuts, cognitive linguistic problems, and he was, not very happy. He was agitated as well as labile, meaning that there were times that he would just, get upset and cry and for what appeared to be no real reason, but that lability was there, as well as impulsivity. So impulsivity is, doing things without thinking of the consequences. And many times that processing is slowed at a level where folks aren't really recognizing the consequences of getting up out of a wheelchair when your left side isn't working well, and so falling and things like that become a real risk. And he was demonstrating many of this. But in the time he was with us, he went from someone who was totally dependent, required 24-hour supervision from our staff in the residential setting, to moving to nearly independent. Now, we know there may be some residual issues, but he was able to perform his ADLs. It says here, he went from having to wear adult attends or diapers because of incontinence. That's a very real problem. It's a very embarrassing issue for many people. He was continent. When he left here, he was managing all of that on his own. He didn't know what to do with his diabetic medications. By the time he left here, we had provided that education, that training, that persistent repetition of what it was that he needed to manage that. He was able to do that. He was able to learn how to scan to his left side so that he wasn't missing things that he was neglecting previously before he came to us. And, he was able cognitively to follow some checklists, right? So that may be a support system, but it's one he can take with him when he goes home. So, hey, here's what my morning routine is. And once he gets it, eventually he'll get it under control and he won't require that at all. So I think, he was able to, it says here, real difficulty because of visual deficits, playing any kind of a board game or whatever. When he left, the guy was playing chess. And so he was able to strategize and see where the next moves were. And, it was really important. And so I think that's just one example of sort of integrating vision, upper extremity issues, bowel and bladder training. And then the impulse, he was a much nicer, part of it was because he felt so much better about what his capabilities were in following, making those kinds of improvements.
Yeah, Chris, great case study to kind of pull that all together. And you're absolutely right. The puzzle is complex, and there's so many pieces. And I'll again using some of my history as a therapist. There's a time where I worked in outpatient ortho as a hand therapist, and one day a patient walked in and he had a stroke. I'm like, okay, well, what? This isn't a hand problem. Yes, your hand does not work, but it's a brain issue. And really his care was he would come to us in outpatient ortho, we'd work on his hand, then he would go to a different facility to work on speech therapy, and he would go see his physician, and the care was very fragmented. And even in the time that I've been at CNS, and certainly you, we've gone from OT, PT, speech therapy, counseling, nursing, and we've added recreational therapy. We've integrated complementary integrative therapy, and residential has always been there. Residential treatment is absolutely critical to what we do. And there are other disciplines that provide this connectedness. And it does remind me even, you can look at our staff as that interdependent neuro ecosystem, right? You have the neurons, the astrocytes, oligodendrocytes, but you need OTs, you need nurses, you need residential therapy, you need recreational therapists. And that because there's just so many parts to put together. There's so many stones to turn over. And I've also worked in places where they're fighting over body parts, or body parts aren't even being addressed, like vision. And so in order to really have that comprehensive approach, you need a comprehensive team doing a comprehensive evaluation and providing that intervention. So we have developed this complementary integrative therapy, which is, like you said earlier, it's kind of a combination of speech therapy, recreational therapy, occupational therapy, physical therapy. And this allows people to also work on dressing, to be able to do art therapy, to do volunteer work, to go to the zoo and to go bowling, charity events, whatever that might be. And if you look at each one of those activities requires a different demand on the person, whether it's physical, cognitive, visual, emotional. And so in order to represent all of those well, you have to have that comprehensive interdisciplinary team. Much like our brain is interdependent, so is our team. And that complementary integrative therapy is a key component to that.
Yeah, I think it's awesome. They've got a nice raised garden over here behind our administrative building, and during spring in particular, it's just flourishing with all that. So they get folks up there and working on it, and it really illustrates that we're looking at this whole person, right? Even though we know the brain's the one that's been affected, the main area that's been affected. So much more has been affected, and that emotional journey that they're going on and trying to determine, not only the fear of what has happened and surviving through that, but what the future might hold. And counseling is such an important part. And it's not just the individual who was affected by this neurological impact. It's all those around them. As you well know, loved ones are struggling right there with the individual. They're with them day to day. They're seeing the struggles. They're seeing the fears. They're experiencing those same fears themselves. And our counseling not only works on things like couples therapy, family therapy. They have, substance abuse groups. They have anger management groups. They have women's groups, men's groups, young adult groups, and they're able to not only see what's going on for themselves in the individual sessions and their family, but they see their peers and they say, wow, there's some strength here because we're all going through this. And many times they can serve as role models for each other in getting through this. And whether it's worrying about, doing homework or being able to use the restroom properly, it helps them make those kinds of adjustments, because as we build our confidence, our self-efficacy, our sense that, hey, I can really do this, it requires that intense treatment. It requires that repetition and modeling and support from those around, reinforcement. As a behavior analyst, we know that's important. And sometimes the strongest reinforcement is from a peer. And they're saying, hey, I remember watching a vision group, watching the OTs, and they had 4 or 5 guys lined up doing these Brock string exercises to focus on various things. And they were all razzing each other, I'm seeing 2, I'm seeing 3, and supporting each other and laughing, but yet working at the same time. And that strength was so important. And educating the family, creating that partnership, because a lot of times families don't know what to do, so they do too much. right? That it's a sense of over comforting is the term I use, meaning that, I'm so afraid of what has happened to my loved one. I'm so afraid that it's going to happen again, that I'm just going to do everything for them. But that sends the wrong signal, right? It means like, well, I can't do this for myself. I need somebody here to do it for me. And that's not very empowering as an individual. And for folks that had these injuries as an adult or even as a young adult, they're wanting to feel that independence, and that inadvertently is taken away sometimes. So we have to educate the families that there is dignity in risk, right? That while we have this, we all feel this duty to care, as a professional in this field, and you as well, we know that we want the best for our folks. We want to make sure they're safe and that everything goes well. But we also want to give them that dignity that they can be as independent as possible and that they have the opportunity to make choices and to be as active and engaged in their life as they possibly can be.
Chris, and I love that concept, the duty to care and the dignity of risk. And there is that balance. And sometimes I think we can, even as providers, be overprotective and not allow that dignity of risk. And how do we then push the boundaries to that treatment setting to really challenge that patient? And one thing I want to touch upon, I have more to say about the family. I have a personal experience that I just kind of want to share, having been on that other side. But it's also important too. One of the challenges that we have in terms of families is kind of recognizing the changes in their loved one, the way that they think, their memory. And it's not just the physical aspect. Sometimes families say, well, gosh, if Pete could just get up and walk again, we'll be fine. But that's not it. If that's part of it. It's being able to think. It's being able to remember. It's being able to, swallow and talk. And that's where speech pathologists have such an important role in what we do, in education therapy in terms of reading, writing, functional math, and all the ADLs that go under that. We have to think of cognition, and I'm really always surprised and perhaps maybe frustrated that there are times where we hit challenges with various payers saying cognitive rehab is experimental. Well, what do you think the cognitive habilitation is? Our education system, and if it works for our education system, why can't it work for this space? It goes back to the foundation and the principles of neuroplasticity, that cognitive therapy is important as physical therapy and occupational therapy and education therapy. And I just wanted to touch upon that because when your loved one can't think well or can't sequence things well, that care burden is significant. And I'll tell you, Chris, you know me very well. You know the journey that I've been on with my own family. I talked about my uncle a little bit, and fortunately, he was able to go through the continuum of care, spend some time here at CNS, and he's resumed roles. He's back to driving. He's back to working. And I'm so grateful for the time that he had at CNS because it was impactful. But I also know with my mother and having a glioblastoma, which is a brain tumor, it was a much different condition. What I learned in that process is, as even a provider who's connected in the neurospace, it was incredibly difficult for me to navigate. My sister, who also works in healthcare as a case manager, had difficult to navigate. And I can only imagine what people do and the struggles they have without the connections, without the knowledge. And I feel that in my mom's last days, the greatest gift that I could give her, as well as my sister and dad, is to be the best advocate and to make sure that whatever care she could get, she got the right care, and to increase the quality of life. But unfortunately, I think in healthcare, you sometimes have this image of a caring system, and it's not. It's complex. It's calloused. It's just a challenge to navigate. And so from that, the impact that had on me is making sure that when families come to CNS, that they don't experience that we can be that beacon of light. We can light the way for them. And this is a refuge for not only the patient who is trying to recover their life and challenge every single day, but we can be the safe haven for the family and the support to the family and an advocate for the person who has the injury. Because being on the other side of healthcare as a family member fundamentally changed my core. And definitely, I hope and I do believe that it changes the way that I interact at CNS, and hopefully doing my part to transfer that throughout our culture that already has it. But if I can do my job of really reinforcing it, it's important. Just being on the family side. So having one family member who didn't have the opportunity to come to CNS versus another family member who did, granted the conditions were different, but I'm so grateful that my uncle was able to come here and to resume his life and his roles again.
Yeah, no, that's great. And I appreciate you sharing that story. One of the more satisfying things that occurs to me on occasion is, as you're aware probably as well, when you go out and do speaking, and I think that's such an important part of what we do, just like this podcast, is getting information out there, because as you said, folks just don't know and don't know how to advocate for themselves, don't have all the information they need. And we always kind of take that educational approach to give people tools that they know how to advocate for themselves even better. But I can tell you, probably every time I get out there in a live speaking engagement and I'm talking with folks, somebody will come up to me afterwards and say, I have this family member, I have this loved one, I have this mother, father, daughter, son, grandson even, and this is what's going on. What do you think? And to spend that a little bit of time to educate and give them a few nuggets that they can then go advocate in a stronger way is always very important to me. And I always feel, if I can help and touch at least one person in my life, I've done something, and so, I think it does show that we're always willing to go above and beyond at CNS. We help folks, using your architecture background there, build and rebuild lives. And sometimes it is building. We talk about rebuilding, but sometimes you got to kind of start from the ground up again, right? And build something that's new to bring them joy and happiness in their lives. And it may be different, but that's okay, because we're able to help them do that. And through the physical, emotional, cognitive recovery and therapy process, all those critical pieces come together to help them rebuild those lives.
Yeah, and that's truly what we want, Chris. Patients' lives to get better every single day, and they're to bring that family unit back together, whether they had traumatic brain injury, a stroke, or any other type of condition that we treat. I think the bottom line here is you cannot have fragmented care, and fragmented care it can be found everywhere, but that's not what this population needs. We need every stone to be turned over. We need that comprehensive interdisciplinary team to look at every aspect of a person, and then how to translate those performance components like fine motor coordination to being able to take their own medication and apply it to real activities. And then the aggregation of those real activities then make us who we are, in terms of my responsibility as a dad and as a husband and as a brother, as someone who is your colleague, and to be able to perform well when I'm around you and all of our other colleagues here. It's those small components that roll up to bigger components to who we are. And you have to not only have the breadth, you have to have the depth of all of that information. And that's why I love what we do. I'm called to serve, and this never gets old.
Yeah, I totally agree. It not only gets old, it's what gets me here every day, right? And after 42, 43 years now, I show up every day with that sense of excitement and just that, that joy of seeing the changes in what folks are capable of doing, or when the kind of the light turns back on and they're like, wow, I can do this. And, here at CNS, we share pictures and stories and videos, and that's all it takes. Right. And you got me for another 40 years.
Ah, yes.
If I make it. Yeah. If I can get through that.
You can make it. You can make it. Yeah. So I think for everyone who's listening, no matter who you are, it's important to remember some of the key points from this episode. Number one, heart health is brain health. Everything you do for your heart is going to help your brain, because your brain needs blood pumping into it all day long. And if you have heart conditions, it can lead to some pretty devastating outcomes. And stroke is common, and it isn't only for older people. You can definitely reduce your chances of a stroke by watching your blood pressure, your cholesterol, eating well, and exercising. But it can still come on when you least expect it. So if it happens, go to a hospital, call 911. Remember BFAST or the FAST acronym, and as soon as possible, because time is precious and it can make all the difference in the world.
Yeah, no, I think that's important. If you, your loved one experiences stroke, we talked about TIAs as well. We know that the recovery, it can be lengthy, it can be arduous, it can be something that's scary and difficult, but you should have hope. I said, first, last, and only, but hope is really at the core of all of that. And we believe that that hope is very powerful, and that, we know that life is important. We know that the quality of your life, your ability to engage with your loved ones is important. And that caring, that hope is what drives us each and every day. So if you find yourself in that position, reach out, call us, contact us, let us know how we can be a part of your lives to help you in that recovery process.
Yes, please. Yes, please. And Chris, I want to thank you so much for talking with me. You and I worked together for decades now. I never get enough time with you, and we get on this roll, and I think we can just talk forever. This is important stuff, and it's important that we recognize the work we do, the service that we provide, and we really help people with brain injury get back to their lives, get back to their roles. And we truly have a meaningful impact on that person, on the family unit, quite frankly, on our community, society, and country. This is mission-driven work, and we were truly making a big impact. And I want to praise you for your work all these years, your mentorship to me. You have truly created a big difference in our space in neuro rehab. You've carved out a space in even behavior analysis. So I want to thank you so much for your contributions all these years, and I look forward to the next 40 years with you.
Oh my goodness. No, it's certainly a pleasure, Dave. I always enjoy, and we go back, we have many more stories than were even brought up today, certainly to go through, and we can even dig up other ones. Some of them may not be for prime time, but regardless, it's certainly been my pleasure. And it, as I've mentioned, it is my passion. It has been my passion, and it's not about me. It's about being able to see what happens in the lives of those folks that are really struggling through this difficult time, this traumatic time, and the frustrations and all the things and challenges that they experience. So it's important. It's what I've loved doing. It's what I feel I was called to do. And if that's the case, then I should be here doing it. And I hope I can continue doing it. And with your leadership, which is just incredible on a regular basis, I think the sky's the limit, and for us and those that we help each and every day.
Thank you, Chris. Thank you. And for all of you who are listening, thank you for participating in the Center for Neuro Skills podcast. As you can see, there's a lot to discuss, and we can fill these podcasts with a ton of information. We have years of content that we can provide, but hopefully you're walking away with information in terms of stroke and prevention and what happens post-prevention. Hopefully you have some inspiration, maybe some direction. We want to be here for you, and we look forward to connecting with you on the next Center for Neuro Skills podcast. Thank you so much.